Okay, so looks like I've got some people who can hear me. Wonderful. Ooh, there we go. So we're going to talk about this document. We have three wonderful speakers today. I think what I'll do is I'll introduce all three up front. And the reason I'm going to do that is while one will be predominantly talking, it wouldn't surprise me if another jumps in if a question comes up that's more related to another's expertise. So we have Joey Fox, Marianne Levisky, and Stephane Bilodeau. So Joey Fox is a professional engineer and has a master's in applied science. He's an HVAC engineer and he's the OSPE indoor air quality chair. He's also very active on social media, sharing excellent resources for how to clean the air. And we've had the pleasure of Joey Fox speaking at an Occ-COVID before, so we're very pleased he made time to return today. We also have Marianne Levisky, who has MES, also is a certified industrial hygienist, registered occupational hygienist, and fellow of the American Industrial Hygiene Association. Marianne was the lead officer on OSPE's guidance on face coverings, one of the 4 documents we're discussing today. She consults with ECOH, an Ontario environmental OHS firm, and is adjunct faculty at the University of Toronto, and was the founding president of Workplace Health Without Borders. And last but most certainly not least, Stephane Bilodeau, who is a PEng, PhD, and FEC, which is Fellow of Engineers Canada. So Stephane Bilodeau is an engineer with experience in ventilation, indoor air quality, and energy storage. He's a bioengineering lecturer at McGill University, CTO at Smart Phases, and World Health Network IAQ Task Force Coordinator. He participated in OSPE's guidance documents being discussed today as well. So thank you all very much for being here. Really appreciate it. We really have wonderful speakers today. So Joey, you're going to be the first one to start. Joey will give a little bit of the framework for what this is. And again, feel free to put questions in the chat.
You're muted.
Sorry about that. Can everyone see my screen? It's just a blank word screen for now. Yes, great. Okay, so I just wanted to introduce the documents that we just put out and just give an overview of them. So if you go just anywhere and you type in OSPE, OSPE, the first result is the Ontario Society of Professional Engineers. And when you go into the website right front and center, there's the indoor air quality reports. So these are the reports that we just put out. We still have another one coming, which is going to be the main indoor air quality document. But you could see the documents here. I'll leave Marianne, who is the lead author, to discuss the face coverings, but I'll go through the other documents briefly. So I'll start with the indoor air quality checklist. So you could click on read now.
We still only see a blank screen.
Oh.
It says you're starting to share content. You may have to say, okay.
Give me a second. Story, share, screen 2. I should have shared this. I apologize. I'll do this quickly again. You could see, so
no,
if you type in OSPE.
It's loaded yet. I think you have to click OK too. Did you see, is there, like you go choose your screen and then click, I think there's an OK button.
It says people are viewing your screen.
It says you're starting to share content. Okay, well, somebody else can go to the website and share.
Okay, someone else would like to share.
Are you doing it, Krista, or do you want me to? Take a minute or two. It's always a wrinkle.
Okay, if there's an issue, I could just try to share the, okay, great. So you go, perfect.
Thanks.
So right in the middle, so you're in the indoor air quality reports. Can you please click on, if you scroll down a little? So we could go into the indoor air quality checklist, please. These are essentially our core recommendations. So we have a much longer detailed guidance on what to do in many different situations, but really this is what people need to do right now. And these are all very achievable. A big failure throughout the whole pandemic is to properly set targets and give clear guidance. It's usually just kind of, do the best you can, improve ventilation, improve filtration, but there's no targets and no specific details. This really has enough to get started. So we'll start with mitigating airborne diseases. So this includes COVID, and it will also help with influenza and RSV, everything that's really overwhelming us right now. They all spread through the air. You could all get infected through inhalation, and mitigating airborne diseases. This is really how on a societal level we can protect everyone without requiring them to actually do something. Our recommendation is a 6 equivalent air changes per hour. So this could be done with ultraviolet light, although that's very rare in Canada. And the options are ventilation, so that's outdoor air, and filtration by using recirculated air and passing it through a filter that can filter out virus particles or respiratory particles that contain the virus. Aside from that, we wanted to be comprehensive with indoor air quality and safety. Airborne diseases has been the biggest issue of late, but really there's a lot more issues with indoor air quality because there are a lot of different pollutants. And we want to be able to address the pollutants and just long-term provide safe, healthy environments for people. Ventilation is the main tool that's used. So our second core recommendation is that places should be brought in line with current standards. Current standards are using cognizant authorities to ensure that the concentration of pollutants is at a reasonable level. We have old buildings that have concentrations of pollutants at unreasonable levels and that are not safe. So this needs to be addressed through ventilation in general. Our third recommendation has to do with filtration. There is a debate. Should you always require a higher level filtration? It's definitely a good idea to always have higher level filtration, to use MERV 13 filters in your air handling units. The units cannot always handle that, but it really needs to be prioritized as the #1 thing when particulate matter is an issue. This is also a requirement by ASHRAE that no one follows. It says you need better filters if particulate matter levels are high. I've never seen that ever done. But we've also listed a lot of places where particulate matter levels are always high. Near highways, for example, in industrial areas, near construction sites. In our guidance document, it lists those out. Those places need to have better filtration, and if you can't use MERV 13, then you need to use a portable HEPA filter or the Corsi Rosenthal box. We fully endorse its use. The evidence is that it works better than almost all commercial HEPA filters. So that's another alternative. Ultraviolet germicidal irradiation using UV light, our fourth recommendation. It can be done in lots of different ways, but upper room UV systems are the ones that have had decades of use. And we're really recommending using these in healthcare settings and congregate living settings. Upper room UV can provide much higher air changes than ventilation or filtration, much better protection against airborne diseases. And healthcare acquired infections have been a huge problem in Canada. It's a huge problem globally. There's hundreds of thousands of healthcare acquired infections every year. And we have tools to address them, but the engineering tools have not been used, or the focus has been, even for COVID, they've closed down wards to do deep cleanings when we know COVID doesn't really spread through surfaces. It's not a significant worry, while at the same time ignoring the importance of the air. Upper room UV has actually been tested with COVID in a hospital, and they found no cases of transmission when it was used. So this is something that really needs to start being deployed and when you're in healthcare settings, you're dealing with vulnerable, immunocompromised people who have many medical issues, obviously, and they need that extra protection. So that's why we recommend upper room UV systems, especially in those circumstances. If we could continue just to the last two. There's still lots of places that are using poor technology that doesn't have evidence. Recently, there was just a paper published showing that ionizers and another method called photocatalytic oxidation both perform very poorly. They're also known to create byproducts in the air, which are not are not good. They're pollutants. These are still being deployed across Canada, and we need to focus on technologies that we know are effective and technologies that are safe. These technologies do not have that evidence that they're both safe and effective. So we need to avoid them, at least for the time being, until we know we have proper procedures established that they are safe and effective. But for the time being, they're not a reasonable alternative and they shouldn't be used. And the last thing is transparency and public education. People need to be more aware. People need to understand that the viruses that are really overwhelming hospitals now are airborne, that cleaning the air is the long-term tool that we need in order to protect people. Not everyone can mask, and many situations you can't mask. Masking is an extremely effective tool to protect you, but at the same time, we also need to protect everyone through the use of better air quality. So this needs to be widely known. Now, we also fully recommend monitoring carbon dioxide levels. We detail how they can be used. You need caution because a lot of people think it just tells you how much viruses might be in the air, and that's not necessarily true, because filtration also can remove viruses, and so can UV when they don't do anything with carbon dioxide. But we are recommending places bring their ventilation in line with current standards, and it needs to be verified through carbon dioxide. What usually happens is you measure it once and you assume that it's working perfectly for the next 50 years. Clearly, that's not a system that is designed to succeed. Ongoing monitoring of carbon dioxide can alert you if the system's not operating properly. So those are the 6 core recommendations that we have. If you go back, please. So I don't know if we need to go, but the core recommendations for safer indoor air, it has those 6 recommendations. And if you could put your information there on the side, and OSPE won't contact you if you don't ask to have that information there. It just goes into more detail about ways to improve ventilation, how to use filtration, how to use the different technologies, what we recommend and don't recommend. But I've given you an overview of what's in that document, and you could look there for more details. And now, we also have a how COVID spreads document, which we thought we wanted to initially fold it into the indoor air quality and into the masking document, because the importance of both of those, why indoor air quality and why masking are important, is because of how COVID spreads and how other airborne diseases spread. But we decided to have our own separate document, which we could reference from both of our guidances when it comes to indoor air quality and masking. Primarily, the main points that we need to understand is these viruses spread really well at close range. So when you're at close range of someone, you're sharing a lot more air with them. If you could think about someone smoking, initially when they breathe out, a lot of smoke is concentrated near their face, and then it diffuses throughout the room. The other time which becomes high risk is when you're sharing a room with someone and there's poor air quality. That the ventilation doesn't remove the pollutants from the space, and there's no filtration. And if that happens, it will build up and you will be sharing a lot more air with them. Also just want to make a point that if you have good airflow through the space, even at short range, it gets diluted much quicker. So that helps reduce risk. People think that good ventilation only works for shared room and doesn't do anything for short range. At short range, it's still going to be high risk, and I don't think necessarily could be a perfect solution, but it definitely can play an important role, having good airflow through the space in order to reduce the risk of even short range transmission. Also, in the document for how COVID spreads, we also deal with a few myths, frequently asked questions, that masking isn't just for aerosol generating procedures. That's a misnomer. Breathing, coughing, talking are all aerosol generating procedures. So if you wanted to mask for aerosol generating procedures, it's always, because everything generates aerosols that comes out of your mouth or nose. Also, plexiglass barriers, which I still see all over the place. A lot of the times they can increase risk if they're not used properly. So we deal with a lot of those briefly in our How COVID Spreads document, just so people could have a better understanding what tools they should use, what's the science behind how it spreads and how you could protect yourself. We have a very detailed MASc document, which I'll leave to Marianne to discuss. And that's kind of an overview of what our group has done so far. We do intend to have more details about indoor air quality. So for example, we've ignored humidity in our current core recommendations, but it definitely does deserve time discussed when you're speaking about indoor air quality. So that will be in our main document. So I think I've spoken enough. If I pass it over to Stephane or Marianne.
Before we go to Marianne, can we just answer the first question we have? Can you clarify how plexiglass barriers can increase and not decrease risk of transmission?
Decreasing, it can if it's used properly. One example I could think of is in dentist offices to separate rooms from each other. So if you have good air circulation and the air is being cleaned, you have MERV 13 filters and you have good ventilation, you won't be sharing so much air with another room, which is a good thing, that you'll be getting supplied clean air or non-infectious air. That's one way between rooms. Now, for example, students at desks with plexiglass barriers around the desk, or in an office setting, or even sometimes in a receptionist setting, what happens is you're messing with you're affecting the airflow in the room. And you could create these dead spots where air is not really being cleaned. And you could have, in places like that, you get a buildup of aerosols. You could get a buildup of pollutants. I'm thinking of like examples that people might be familiar with. But let's say you have a spot on your desk that you never dust off. It's going to start collecting dust after a while. Places that have good airflow, the pollutants will get removed. But plexiglass can actually increase risk. And it was shown that when used in schools, it increased the risk of transmission just by not having proper airflow through the space and trapping those aerosols really at your face height where you don't want them to be.
That sort of gives a bit more proof to the aerosol nature as opposed to droplet nature. If it was droplet, those plexiglass barriers would not have resulted in an increase in transmission. So that's just food for thought for those attending.
You do find some cases, I'll just say, where some measure, plexiglass would be fantastic against spray transmission. And you might find some measures that help with in one way and hurt in another. And that's when you really need experts who understand the full, all the different methods, how they interplay. What's the best way forward? Because you could be helping yourself in one way, but hurting yourself much more in another way.
That's a great point. And I love your dental office example. I'm going to copy that and use that, I think, going forward.
Yeah, I guess just from an engineer's perspective, if you have a supply and a return in the same area, then having just air mixing in that area is good. If you have a supply in area and a return in another and you put a barrier between them, then you can have trouble having proper flow through the room, and that would increase risk. So I know I always look at ceilings when I see plexiglass barriers. Where's the supply? Where's the return? Is it going to start causing issues? That's more of the engineering side for people who are familiar.
Great. Catherine commented, and I'm just saying this out loud for those who may not see the chat, that at healthcare settings in where she is in Montreal, Quebec, she regularly sees waiting area seats separated individually by plexiglass. And I know I've definitely seen that in Ontario and in other settings too. So I don't think it's restricted to one province or one region. It was a very common protocol. I think, Dorothy, your question is wonderful. I'm going to move on to Marianne, but I want you to know that I'm not ignoring your question. I will come back to it. I will flag that. So we're going to move on to Marianne right now, though.
Thank you. Okay, are my slides visible and you can hear me?
Yes, all good.
Okay, good. So as Joey mentioned, I was the lead author of the face covering piece of the OSPE documents, but I certainly had a lot of help and input from many, many people, some of whom I'll probably mention in this brief presentation. So, whoop, it's not advancing properly. And it did when I tested it. Let's try that again. That's really odd. Does anybody know why it wouldn't be advancing
No,
right
it
when
was
it
showing.
worked fine before? Yeah, but it's not advancing. Oh, no.
Can you
Wow.
try it with your mouse instead of with arrows or vice versa?
That's what I was doing. I tried both.
We could look at it this way, I guess, but it's not as.
Yeah, I might have to do that because I don't know why it's not working.
Or I can try and
There
share.
it goes. Okay,
There it
seems
goes.
to be working now. Good. Okay, so I mentioned this already. It's a part of the OSPE's document. It's intended to be introductory. It's fairly high level, and most of you probably have been to other OHCOW webinars on respiratory protection before, and so it will all probably be review to you. We really wanted to make it mostly useful to the general public who may not understand some concepts about respiratory protection and masks. So it does mention workplace requirements, but quite briefly, and refers people to other sources for that. So today I won't really concentrate on the workplace, but about just more of the general points. So what do I want to cover now? Just give you some highlights, not go through the whole document, and then provide some details on a few points, even with some information that is not in the document, just maybe to delve into a few things that I think sometimes are forgotten by people with regard to face coverings. And then a few thoughts about why wear them now. Probably don't have to convince this audience, but maybe we can help use these arguments for the general public discussion, which is quite prominent these days on masking. So just a note about the terminology as used in the guidance. We've been using the word face covering to mean all those things you put over your mouth and nose to protect yourself and others, whether it's a mask or a respirator. And then define respirator, which is an approved by a certifying body such as NIOSH and CSA as meeting a standard for respiratory protection. A mask is kind of everything else that's not an approved respirator, and face covering applies to all of the above. So what is the main recommendation in the document? It's simply to reduce risk, both of inward and outward transmission, either becoming infected or infecting others. Wear a well-fitting respirator or other face covering that provides particle filtration equivalent to what we know as an N95 when you are in indoor settings or crowded outdoor areas. Especially, and I would add especially in places, you know, in public areas. Sometimes you may want to do it in private areas as well. You hear a lot of people talking about high quality face coverings, and we kind of steered away from that term because we didn't think it was defined well enough. So that's why we say this really is what it means by high quality face covering. It provides a certain level of filtration as well as fit, and that's how we define it. So here are some other key messages in the document. The first one I kind of covered. If you don't not use an approved respirator, select a mask that has that equivalent filtration, and there are many now being used that would not be defined as a respirator because it wouldn't fit quite the same, but it has pretty much equivalent filtration. So we see many people wearing ear loop KN95s, for example. That might fit into this category mentioned in point 2. Get as good a fit as possible, whether it's a respirator or a mask. There's certainly ways you can get better fit. If you can get it fit tested, I'll cover shortly what that means. But if you can't, learn how to get the best fit. And there are certainly a lot of techniques. Mostly it's not gone into detail in the document, but there are links to help you learn how to get good fit and check the seal. We note that respirators with headbands usually fit better than masks with ear loops. Of course, that there are individual differences, but we understand that ear loops are inconvenient for, headbands are inconvenient for a lot of people. So if you do use ear loops, still learn how to get really good fit. We know that face coverings can be reused. Of course, things like N95s The surgical masks, they're not intended to be washed. Do not wash them. But there are ways you can store them between uses so that by the time you use them again, they would be safe to use. And just a note that where it's used in the workplace and required in the workplace, there are a lot of legal requirements that apply. And we note that, but we don't necessarily go into a lot of detail in the document. So there's also some explanation of what these terms mean. And I find this is kind of useful for a lot of people because people use the word N95 a lot and not really understanding. They think N95 maybe applies to everything that we consider a filtering face piece respirator, but N95 is actually one particular type. The generic term is filtering face piece respirator, or FFR, which means an approved respirator in which the whole face piece is the filter. The best known one is N95, but you can certainly have others. The 95 means it filters 95% of the most penetrating particle size. I'll get that into a minute, to that in a minute. The N just means it doesn't protect against oil-coated particles, which is not relevant for our purposes. It's relevant when used in industry. So you could have a P95, which means it protects against oil-coated particles. That would be perfectly fine for our purposes. It's just that it's not necessary. And then we have other terms called KN95, which is Chinese standard, KF94, which is a Korean standard, FFP2, FFP3, which conform to European standards. Then we have the term particle filtration efficiency, PFE. And that relates to the box above about what the level of filtration of the most penetrating particle size. Then I just wanted to note what we mean by NIOSH approved. It's approved by the U.S. National Institute for Occupational Safety and Health as meeting respirator standards. And I also did want to note that Health Canada has a really good site, which you can check. There's a link in the document to check whether Health Canada authorizes these masks or respirators. And it doesn't mean it's approved to a standard, but it gives you some assurance if you're using a mask, not an approved respirator, that it does do what it says it does. So if you're using a KN95 or KF94, it's good to check that Health Canada site. Okay, so I want to get into what we mean by those filtration. And first I want to mention the 3 Fs. I give credit to Simon Smith, who has presented to OHCOW before. Please go back and look at his presentation. He's always very thorough. And I think he came up with the idea of the 3 Fs as being the most critical factors for whether you're getting good protection. So the 3 Fs are filtration. How well does it remove particles from the air? Fit, how well it fits to your face so you don't have air leaking around it, and function, how easy it is to breathe through, how comfortable it is to wear. Because if you don't feel comfortable and you can't breathe, you're not going to wear it and it won't be any use. So the 3 Fs are the important things to remember in choosing a mask or a respirator. So let's spend just a minute or so on the idea of how filtration works, because there's sometimes a lot of misunderstanding about it. And this is a site that was an interactive graphic that the New York Times put up. I strongly recommend it because I think it actually moves, and I didn't want to take a chance of doing it on screen. But, you know, this really gives a good understanding of the idea that filtration for respirators and for HEPA filters is not the same as a sieve. We think of filter as being something like a colander or a sieve you put in your sink and you pour your peas into it. If the peas are bigger than the holes, they'll be captured, they won't get through. So people think, and I think very commonly we hear people say, well, the virus is smaller than 0.3 microns, the filter only filters 0.3 microns, therefore it's going to get through anyway. That's a misunderstanding for several reasons. One, the virus is inside larger particles, but even it was just 0.3 microns, it still is captured by other mechanisms. And that's illustrated by this New York Times graphic. And they actually give a very lovely little blow up of the filters in an N95 respirator and point out that there's different mechanisms, including electrostatic charges. So those particles that can get through the holes in the fibers will still be captured by an electrostatic charge. So here is a graphic, and don't kind of worry about all these fancy terms, but we just wanted to illustrate something, which is, I'm going to try to use the laser pointer. So there are actually all these different mechanisms that capture the particles, not just filtration, not just the usual sieve mechanism. Some of them work on the really small particles, and the x-axis here is the particle size. So they work on really small particles, and some of them work on large particles. So you combine all these different mechanisms, and you'll see there's one, that's the black line here, one overall filtration efficiency. And when they evaluate for filtration, they say, how much is being captured at this lowest, most penetrating particle, the ones that are going to be captured with the least efficiency, which is about 0.3 micron particle size. So that's what's being measured at 95%. So we say 95% PFE, you're actually getting more than 95% because the smaller particles and the larger particles are being captured by these other mechanisms. So I wanted to make that point. It's mentioned in the document, not in this much detail, but I think it's important to understand that because we often hear people saying, you know, the filter doesn't work because it's only for 0.3 microns. That's wrong. That's a misconception. Okay, so going on with other points mentioned in the document. We mentioned fit tests and seal checks. Krista talked about this a few weeks ago, so please go back and look at the webinar with Krista and Roy McKay, which went into great detail on fit testing. So please do see that. But just for a quick review, the purpose of a fit test is to select the best type of respirator for you. It's not something you do every time. It's just to identify which type is best for you. It's required when respirators are mandated in the workplace, but usually it's not done when used in the community, or if you use it in the workplace on a discretionary basis, it's not really under the Occupational Health and Safety Act. It's usually not done. But if you have a chance to have it done, it's a really good idea to choose a respirator that works for you with a fit test. A seal check is something different. It's a way of checking that the air is not bypassing the filter, and it should be done whenever the respirator is put on. And here's one of Simon's slides, again, that just gives an illustration. Again, Krista and Roy McKay covered this, so I'm not going to explain this all in detail, but there's such a thing as a qualitative fit test, which again, determines whether you can taste or smell some kind of challenge substance. There's a quantitative fit test, which uses an instrument to compare particle concentration outside and inside the face piece. So that's how you do a fit test. And then the seal check is what this person over here is doing on the far right, to check when you put it on, is air coming in or out of the face piece.
Can I interject with a question?
Yeah, sure.
Question actually, it came out a couple minutes ago. I was just waiting for a spot that was made to stop, and I see that seal check, and this is that type of respirator it's asking about. How do we help workers advocate for more comfortable N95s if they aren't getting a comfortable fit, if their employer has only given them that 3M, that cup style, to tell them, like, how do we help them be more comfortable basically in it? Or advocate for them to be more
such a good question. I mean, certainly if it's a program required under Health and Safety Act, then they do have to do a fit test, and they have to find one that's right for that worker, which means they can't just get, one size fits all, everybody has to get the same one. That would not satisfy that requirement at all, because every face is different, and different types of respirators fit different people. So just on that basis alone, I mean, I realize comfort is not the same as fit, but you definitely want to have a range of types of respirators. And it's certainly true from, my own experience, is that cup style is probably one of the least comfortable types, especially if people need to wear wear it for an extended period of time. There's so many better choices now. I've just been really impressed that throughout the pandemic, we've been getting better and better choices in filtering face piece respirators and other types as well. And they're not even more expensive, you know, they're not necessarily a lot more expensive than the cup style. So I think it's a matter of education. I understand that if somebody has to wear it like for a full shift all day, extended period, it can be very uncomfortable. If not, you know, I've seen people whose faces can get very irritated wearing the cup style all day, whereas that doesn't necessarily happen with some of the flat fold styles. So yes, I think it's a matter of education, and certainly it's in an employer's interest to make sure their workers are comfortable. But if it's illegally
it's not
required,
a cost difference anymore either. It used to be that the cup ones were quite a bit more inexpensive.
Yeah,
not the case anymore. So I think that's exactly it. It comes down to education.
Yeah, but thanks. It's a good question. I just wanted to mention again in the document, mainly this does this through links to other sources. But if you do have to use, if you are using a respirator, a headband respirator, do learn how to put it on properly. True for ear loop as well. But there's some really good resources, really good videos online. The manufacturer usually has some instructions. The OHCOW has some really great fact sheets. CDC has a good fact sheet too. Holding it in your hand like this with the straps down is a really good tip. I find often people don't realize that that's much easier way than putting it on, to start it in this position as in the CDC guidance, and then OHCOW has a similar one here. So just check those things to learn how to make it a lot easier for you to put it on. And as Val said to me yesterday, I was talking to her, the best face covering is the best one that you will wear. So if you really hate the one that we just had a question, you know, if it's really uncomfortable, if people feel they really can't wear an approved respirator, what should they do? If it's not a legal requirement and they want to go to something that's not really defined as a respirator, basically something is better than nothing. And we kind of wrestled with this. This is a direct screenshot from a piece of a recommendation in the document. We need a layered approach. We've been saying that all along, as represented by the Swiss cheese model. You've probably seen this graphic in many different places. This is a version, was in the New York Times. We need many different types of prevention. And even poor prevention is better than no protection, especially if it's complemented by those other respirators. So while we're saying a well-fitting N95 or equivalent respirator should be the standard, if you can't do that, using a less efficient mask is certainly better than nothing. And I'm going to spend a little time now in what that means. So first, I just want to go back to Simon Smith. He didn't put his name on this, but that's him in these pictures. Simon, some of us know him pretty well. We're in the Canadian Aerosol Transmission Coalition, as are other people on this call. And he had prepared this slide. I'm not sure he showed it to you when he spoke, but he let the coalition use it. And essentially what he was showing was to answer the question, how well does a surgical mask protect you? So you're not supposed to do a fit test quantitative fit test with the surgical mask, but he did it just for fun. So at the bottom picture here, it shows the results when he tested an N95. We got a protection factor about 200. Remember, that's the comparison of the concentration of particles outside the face piece to inside the face piece. When he did it with a surgical mask, he got a protection factor of about 2. And he pointed out that was about the same as putting his hand over his mouth. So if you feel you could get sufficient protection with your hand over your mouth, you might be satisfied with a surgical mask. Does that mean you should not use a surgical mask? Well, let's think about that for a minute. So this is, again, from an OHCOW fact sheet. There is a similar document on the University of Minnesota site. And what this does is it if we assume, and this is an assumption, if we assume that the time to get infected, if you're in a room with aerosols, infectious aerosols, and you would get infected in 15 minutes in that room, how well would you be protected wearing these different types of face coverings? So these percentages here are the percent leakage into the face piece, either through the filter or around the filter for all these different types. And so if the source, the person who's infected, is wearing something, the same level of outward leakage. Okay, so that's what these two axes mean in this chart. And the numbers in here are the times to infection. So it's a way of comparing how much protection you're getting if you're, and it means you're a non-fitted N95, and this one is a fitted N95. So you're getting 10% protection. And what I did is just calculate in the next slides, just I took those same numbers and I, whoops, I'm not, yeah, and I just calculated the times, the comparison, the number of times protection, just as way of translating it from time to actually level of protection. So if we assume if source and receiver are not wearing any face covering, we call that, you know, likelihood of 1. And then all these numbers are sort of the level of protection you're getting with all these different combinations. So again, if both people are wearing fit tested N95s, it means you're getting 100 times better protection than if neither are wearing anything. So that's what we take from this. So if you're wearing a fitted N95, you're going to get 10 times better protection than if you're not wearing anything. So what does that mean? Does that mean we shouldn't bother? I mean, it's 10 times, or if you're wearing a surgical mask, you're going to get twice. You saw that that was the factor Simon showed. You're going to get twice as much protection. Is that not worth doing it? Well, I would say it's better than nothing. And I just wanted to leave you with a few thoughts about how we need to think on a population level as well as an individual level. So even though your own risk, you know, you can make a decision for your own risk. Okay, I want to be protected 10 times better than nothing, or I'm willing to risk being protected 2 times better than nothing. That's your own choice. But we also have an obligation to the society as a whole, especially right now. And on a population level, these small changes can make a big difference. So even wearing a not very protective mask is better than nothing when it comes to protecting the population. And this was really brought home to me with some tweets from Trisha Greenhalgh, a UK physician. I think some of you follow her on Twitter, really worth following her. And she has a whole series on masks, copied some of them here, and talking about just that thing. We're interested in how we can control the exponential spread of an accelerating pandemic. And she shows if we take, say the, you know, it's spreading, reproductive numbers 2, one person is infecting on average 2 other people, as illustrated in this graphic over here. So if after 10 cycles, you would get a certain number infected. She has 20 cycles here, 262,000 infections. She said, if we reduced it by a tiny amount, after 20 cycles, you're going to get 60% reduction. And I did that same calculation with 10 cycles. So 2 to the 10th, I got 1,024 infections. If you reduce it to 1.9, one person, obviously you're not going to infect 1.9 people, but on average, you might infect an average of 1.9 people. You get 60% roughly of what you'd infected. So a tiny, that's 5% reduction leads to a huge reduction in number of infections. And then I found this super site. Go to this site and play with it. It's really cool because obviously epidemiologists, and I'm not one, use much more complicated equations for figuring out spread. And this is the calculator to help you do that. And you can actually change the values on this side, right on the website. So this starts with the number of infected people, 1 person, and I put in the same numbers that Trisha Greenhalgh used. And what we came out with after 10 days, I changed the number of days. Because I wanted to kind of show up quickly. After 10 days, if we had that little bit of reduction, we prevented infections in 56,000 people. Again, it was about the same number she had, about a 60% reduction. So if we're not doing it to protect ourselves, let's do it to bring down the rate of infection in the population. And I would remind you, this is going to work for other infectious diseases, not just COVID. We're dealing with flu, we're dealing with RSV. We, have every day we have news items saying our hospitals are overwhelmed. They can't treat our children. There was a great interview with Joe Vipanda, doctor in Alberta, whom I think many of you know. I think he spoke at one of OHCOW's webinars. Catch this interview with Natasha Fata online. There's a picture of it here. But he makes a great case for that. What are we as a society if we don't care enough to wear some masks to try to reduce this spreading in infection rate and sort of help the overwhelmed healthcare system? I don't think I need to make that case to you here, but it might help in terms of explaining it to other people. So just wanted to leave you with some references. Sometimes we get a lot of questions, where can I buy respirators and masks? As we just mentioned with Krista, there's much more available than it was earlier in the pandemic in many good places, even places I never thought of getting respirators, like Staples. Who knew? They provide some really good
I've seen them at children's clothing stores.
Oh, yeah. And then there's some good online sources as well. Here's some other online sources. Do check out OHCOW's webinars and resources. They are really, really good. So that's kind of what I wanted to say. Thanks.
I think I have one question left before we open it up to Stephane. Was this done, these calculations, were they done with a specific variant in mind, or were they just mathematical models showing the reduction?
Yeah, it was just a mathematical model, and you can change it. So in fact, well, if I go back to that, you actually can put in the infection rate, or the what would be the R number, the R naught or the RT number. So, you can put that in. Yeah.
The one that was looking at the 15 minutes to infection, that was just the assumption.
Oh, I'm sorry. You're talking about that one. I was talking about the calculator. Yeah. That one was based, you know what it was based on? It was based on, at the very beginning of the pandemic, you might remember CDC, US CDC said, their recommendations were based on 15 minutes to infection. Remember?
Okay.
And we were never really sure that was correct, but it was the only number they had at the time. So they used it as a hypothetical number as the starting point, and then based all the other times on that. But
and those times are based on how much filtration you're getting out of each mask.
But that was, as say, at the beginning of the pandemic. It wasn't taking Omicron into account, which is much more infectious, and it probably would be much less time now. So that's why I wanted to use it to show the difference related to that reference time. Don't pay too much attention to the time, but the level of protection would still hold.
Thank you for clarifying that.
Can I ask another question? It's about the leakage, the values of 20% for non-fit tested and 10% for fit tested. I believe those are values that predate the pandemic from research done previously. As you showed in the presentation, there was a fit factor of 200, which I believe is 5% leakage. And I could tell you myself, I would not have done a good job putting on a respirator 3 years ago, but I've learned how to do it much better now. So is it possible that these 10 and 20% numbers, really because of better education and better experience, they're actually much higher and you get better protection than what was measured pre-pandemic?
Very good point. Yes. I mean, I think they built a safety factor into those numbers. That's true, especially into the non-fit tested numbers, because we really have no way of knowing how well people, would put on a non-fit test.
It depends on how seriously someone takes it and what the contaminant is. So, for instance, if I had to wear a mask, which I have had to wear to go into a surgical area, I'm just putting on the mask because I know it's protecting the room, because it was an empty room at the time, from me. Whereas when I was putting on a respirator for asbestos, and I knew there was asbestos in there, you best believe I was pulling those straps as tight as I could, doing my checks, because that was for my protection. I think there's a bit of a thought process around what you're going into. So if you're visiting someone and you're in a crowded space and you want to be protected, someone could, I would think, give themselves better protection by making sure the respirator is nice and tight and snug.
Yeah, but that was a good question, Joey. I think even with the fit tested numbers, they're building some safety factor in there, because even if you pass a fit test, it doesn't mean you're going to put it on optimally every single time.
And Louise commented, she thinks many people have believe they are protected for 15 minutes without a mask, and this belief is a problem. I think you're absolutely right. 15 is not a magical number. We're at 14 minutes. You're safe. In 15, it's an issue. I think that 15 was just, I think, an assumption. It may have been based on some data. I haven't seen anything published on it.
Well, just remember, whatever it was based on, it was the first strain, yes. The wild type, they call it, the first iteration of the virus. Omicron is way more infectious than that was. So if it was 15 minutes then, it's going to be much less now. So, I mean, I think like many people here probably, I mean, I put on in 95 when I go into a store and I'm not in there in 15 minutes. Right. Why take a chance, right?
Yeah, I think there was a question. Also, if I could just, there's a lot of factors that contribute to risk. So the assumption there is it's a 15-minute time based on the factors, but there are other factors, whether or not there's good ventilation and air quality, how far you are away from the person, what activities you're doing. So if you're, if you're exercising or screaming, it's much higher than talking, which is much higher risk than breathing. Breathing is not a high risk activity, although it can still spread. And also it depends on like your prior immunity. So there's a lot of other factors that are at play. I wouldn't put much stock in those numbers, but it's for a relative comparison of the dose you're getting.
Right, absolutely. Yes, I think that's really important to emphasize. And that's why I took those numbers and just converted into relative numbers. So I would really just think of it as a comparison, not an absolute amount of time.
Thank you. We'll go on to Stephane for your section. I did see a question from Fran. I will get an answer for you on that. I won't forget. So I'll turn that over to you.
Yes, I can start, and I will talk about the 15 minutes in a few minutes. I have a small presentation. I think Marianne did a great presentation talking about the importance of mask as being a barrier, and Joey started with explaining the process that went and what was the recommendation and what are, I should say, the recommendation from OSPE. I just want to first emphasize the importance of this, and in the few slides I'll present, I'll show I would call that the context. But OSPE is definitely the first substantial or big or engineer organization in Canada that puts formal recommendation on the table. And this is an important step. The engineering profession needed to go forward in that, because part of the protection or the precautions, and I'll show my screen in a second, are definitely related to so just a second, should be starting right away. I hope I'll be able, you should see this now. So it's part of protecting ourselves and the persons in a room against the airborne transmission or the aerosol transmission of SARS-CoV-2, more precisely right now, but also all the other viruses that are transmitted or transported, if I want to be more general, in the air. So they are floating essentially. So this is important, an important step that OSPE came with, and the committee that was built to make that, and under the leadership of Joey is an awesome, definitely an awesome endeavor for Canada and even beyond. So what I wanted to highlight just a few things, and some of the things on top of the importance of the OSPE work is what Marianne came with towards the end of her presentation. So we're not only doing those things, so taking precautions like mask or ventilation or respirators, definitely more advanced respirator, we're doing that also for the others, either the most vulnerables in our society, those who have comorbidities, but also the young people. We see the children hospitals in, from the East Coast to the West Coast in Canada, they're overwhelmed right now. The elderly person, so we saw that from the beginning of the pandemic. So these are all subset of our population which are more at risk than everybody else, more than everybody else, and we need to do that for them as well. So it's a protection from for ourselves, but definitely even, and I think it's even more important towards the others. So that's a bit of few things I wanted to highlight. So I give you right away the two conclusions of my presentation: importance of the OSPE, second, the importance of the OSPE work, and the importance of precautions in by themselves to protect more than just ourselves. All starts that starts from the hierarchical control. Absolutely, many of you and in this world knows that, because it's touching the work of so much occupational hygienist. But right now we're dealing with a special context, which is on the right side of this slide. Let me use the pointer. Yes. So this is the context where you see at the same time closed space, crowded places, and close contact settings. So that's where you need to add to your controls, to your precautions. Just one might not be sufficient. You need a few of them, and it comes to my next slides, which Marianne highlighted a bit, which was in fact publicly referenced in many places, the New York Times, as Marianne said, but also this is from Dr. McKay, working with Dr. Hygienist, which you might know as well. And they were, I like this one, that's a variation, but I like this one because one part of these barriers, I should call that layers, but I prefer to call that barriers, because there's a barrier against these aerosols or viruses loaded. So it's the personal responsibilities, and then you have the shared responsibilities. You have things that you need to do collectively, and you have things you can do yourself individually. So, and those barriers are not competing against the others; they're complementary. So we need to do them as in fact many of them, and depending on where you are, if it's a setting like what I just showed with all the 3 C's, so the close contacts, the confined space, and the crowded space. So definitely you'll need more precautions and protection than if it's not. And engineering controls, which are at the basis of most of the recommendation, but for those touching the respirators, are essentially in this middle place in the hierarchical control, because they can touch more persons at the same time. Doesn't mean you don't need to have the others, especially when you're dealing with special setting when you have more people, but also more vulnerable people, especially. So you need many more layers, as was just said here. FPP3 or the N95 here, or even N99. Marianne gave a better explanation of that. Definitely have been proven to help a lot, not only theoretically, but also in the data, in the results. That's different than the plexiglass. So talking about the question we got a few minutes ago. Plexiglass, maybe they can be helpful as a barrier, wherein you're at a counter at the grocery, for example, 2-3 feet away from the cashier, and you want to protect this person against the big droplets that you might, if you cough or something like that. So that might be okay. But studies in Massachusetts, others, and I think of a British study that was released last year, showed explicitly that they can increase the risk. So the risk of being contaminated, infected in some settings. And so amongst them, there was classroom, and there was other things like that were, it's, as soon as you're dealing with aerosols, so very tiny droplets that would continue to float in the air. The big difference between the bigger droplets and the micro, so the aerosols, is the fact that the aerosol are able to to fly, I would say. Okay, they're able to float in the air and stay there for a long period of time. And that's definitely different than the droplets that will fall like a ballistic missile, if I simplify. So they will just fall because of gravity really quickly. The droplets are floating because of their buoyancy capacity. So in the air, they stay there for a long time, so they can be crossing a room meters away from one wall to the other wall really easily, and then they can stay there and continue to float in this big soup we have around us. So it's a soup of so many things, and we want to have it the cleaner possible. So anyway, that's the hierarchy of control point. So, and you need different barriers for aerosols than for droplets. That's my last point. Other groups have worked on finding and establishing recommendation. Indeed, on the world stage, the ASHRAE came in quickly early at the beginning of the pandemic with their task force, and they came with repeated addition and validation. But as I said, there was no one equivalent to that in Canada. It was more an international endeavor. Here in Canada, we have specifics and we have things that needed to be touched more specifically, and that's why it was so important, the work what was done by the OSPE. So these recommendations I've touched some of the things that were directly addressed in the OSPE recommendation, but the OSPE went even further, talking about even the exchange of information, transparency, for example, and talking a bit more about, for example, what we do with the different type of ultraviolet systems. So some of them are really recommended, others are not, as we might talk a bit further down the road. There are others like that. So the Federation of European Heating and Ventilating Air Conditioning, in fact, the association, the Federation of Association did also work on that. The MIT did many things and put many guidelines and things on the web. A group which is called COVID is Airborne has also pushed and published so many things in the last few years. The last 2 years, in fact, we're almost getting into the 3rd year now. And then went this great recommendation. That's the simplified version that Joey talked about a bit earlier. But I want to emphasize the importance also of things that are recommended and things that are not. I just opened on the UV, so UV GI, so the germicidal irradiation, so UV germicidal irradiation is definitely recommended, but when you're touching some other types of UV, which are in the area where people are breathing directly, are exposed directly, so it's not like the far UV or the UVGI, then you start to need more, in fact, the professionals involved in the design of these, because it's much more complicated than other solutions which are simpler. I think here of filtration or ventilation, which definitely have great impact, definitely proven impact, but much less potential downside. So, and they can be implemented easily, typically, depends on the type of building we're dealing with, definitely, but much less complicated, let's say it like this. And the other things that were also highlighted is avoiding additive air cleaning apparatus or its special device. Here we're talking about ozonation, ionization, and all those things that creates byproducts which you would need to deal with in some special laboratory in space lab or whatever. You can cope with that, and the equipment can be there, the specialists can be there to deal with these, and they can do a really great job. But when you're dealing with other type of setting, whether it's a school or whether it's a I would say the general type of workplace, this is not the same thing. So you would need to have the capacity to monitor what's going to be produced here. And this is why the recommendations are more on the other way. And the last one is transparency and public education, which is to be done correctly, which is to be promoted in a good way. We just talked about the 15 minutes earlier. So this 15 minutes, with which people came with at the beginning of the pandemic, had kind of distorted the way people were seeing these this transmission. So and it's normal. It was coming from up above, that as soon as they don't stay much more than 15 minutes in a room, either if it's with many persons or not, if it's close contact or not, as soon as this time is respected, they would be safe. This is not working like that, especially for aerosol, because these aerosol can be there even before you're coming into this room. Essentially, if you're coming into an area where there were people, infected people especially, and they were there for a long time, the proportion of infected aerosol floating in this air is quite big. And as soon as you start to breathe in this soup I was referring to, you take those in. So this is so this 15-minute was based on old thing. I don't know if I can switch my screen just to show you, but I want to give you an excerpt of one of the things I show to my student at McGill. So it's just on top of it. So many of the things that are behind the droplet dogma that we saw in the last few years, that let the people think we were dealing with droplets for too many months rather than dealing with aerosols. I recall that droplets are the bigger one, which falls like ballistic missile, while the aerosol would. This is coming from this chart, or the extension of this chart, and worked by Wells, this famous Wells, which you might not know, but in the aerosol world, he is known. That's a 1934 study. 1934. It will be 100 years old in just a decade, a bit more. Okay, and that's very far from the new studies we are having right now that are talking about the displacement. We can monitor a lot of the things, and that's in the last 2 decades. A lot has been done in that. But it's like if at the beginning of this pandemic, we were back into the 1934 data, and that simplifies everything. And so much that we came with this 15-minute dogma, and you know that there are a lot of studies. I will not show that because that's more for the course I'm giving. But the point is, it was not coming from nowhere, but it was coming from far away in time, so another century. And you know, this study, in fact, made some children, I would say, and that were kind of using this, and that was used for decades after that. Anyway, the point is, this is important, the recommendation, because it set the table for people in the engineering world and in the building, the operation, and also in the occupational world, that there is something else than just this simple big droplets, and we need to take precautions, take measures to avoid letting them reach our respiratory system. Okay. Sorry, I just need to get back here. I have a couple of other questions I want to address because I've been asked a few times for that. So the other point, which was misunderstood from the beginning, and which is also in the recommendation, is the air purifiers. Since November 2020, in the very context of SARS-CoV-2, there was a big study carried on in the UK that proved it was an important, and it could be an important layer in our layers protection here. So that's known since more than 2 years now, but still it took more time than that to. Indeed, in Canada and in Ontario especially, there was really good examples of application of that. You saw that in the classroom, for example. But in many provinces, it wasn't the case, and it's still not the case as of now. So there is still resistance, a bit like changing the 15 minutes or whatever downside of it at the same time. So this was proven, and not only studies were showing the positive impact in reducing transmission, reducing the risk of infection, but also it is a measure that is a really good complement to other measures. So it's not in competition, as I said, it's a complementary measure. The other one that for which I have many questions sometimes is the windows opening, because it's pushed so much by many authorities of many sorts. Indeed, if you're dealing with aerosol, one of the things you want to do is to clean the air. One way is to use the filtration, as I just showed. The other way is to replace the air by cleaner air, outside air as much as possible. So windows have this capacity to let air in. The issue with windows is the way you control them. So if you're in a building which is in fact, in a room in this very building, which is facing northwest, for example, in Ontario right now, wind are in fact mostly coming from northwest because of the winter season. So if you're facing this north direction, so in the room, in the classroom, in your whatever setting you're in, then opening the window would let this air coming in. That might be cold air, but that's another question. So that's okay. So you'll get fresh air. But on the other side of the building, they're facing south, southeast, southwest. So it's completely different what will happen. So if there is always in the middle or whatever, it's another set of classroom. What will happen is the air coming in your room from the north side to the hallway, to the second room. So you understand now that the air that they will receiving on the southward wall will be the air coming in from inside your very building. And if in your room there are infected people, you're pushing all this infected fluid or mass of air inside other area of the building. So you start to understand the downside with windows. Yes, it's not a bad thing if you're in your house, if you're in a small building, but as soon as you're dealing with bigger installation or facility, then it starts to complexify everything. It changes even the general circulation of the air in the building, and that's not necessarily what you will want to do. So in special setting, design for that, you can use what we call natural ventilation, and you prepare the building for this to happen correctly. So this flow of natural air coming from whatever windows or openings you created. But when your building is not designed for that, and if it's a big building, using this is not a solution. And not only that, during the season, this direction, the wind direction will change. Second, the temperature of the air will change as well. When it will be -20 in a few weeks, indeed, you know that the cooling down the room might be very, very fast if you open the windows really widely. So this is another thing, and I just wanted to highlight this, and that's why we need solutions like those which are in the recommendation. Others have put recommendation on the side. WHO a year and a half ago came with a roadmap, which is not as detailed as the recommendation, the OSPE recommendation, but the intent is to explain that this is essentially a roadmap. So you need to look at your specific, at your building, at your type of occupancy, all the things, and then you decide which solutions, with an S, which solutions you will want to add to this facility. And it is a roadmap because of one big thing. You might not be able to modify everything day one. Some of the solutions might be coming very fast. If you need to add mass to your workforce, give mass to your workforce, that then can be done quickly. But if you need to change settings and equipments in the big central ventilation system, that might be a longer thing. But as soon as you set a roadmap, a plan, if I say it another way, you start to work on it and you're making improvements and you're changing, in fact, positively the situation for those who are working there or the occupants or whatever. Indeed, there are others. So I see IGH have put great recommendation, maybe even the white paper on that. The UK government is really having a lot of stuff, so it's a really good reference. Yeah, Shreya mentioned it. So the roadmap, in fact, what was suggested by and what is to be used and suggested by the OSPE, think of it as a roadmap. There are many recommendations, many things that can be done in your own situation. Start to work and use and apply those who are low-hanging fruits, those you can be applying quickly, and then you make a plan for the midterm and longer term. That's the way to go to make sure that you're improving on the long run. You're improving the situation and you're making your people, your workers, safer. So that was essentially what I wanted to just to introduce the context and the importance of what we have to show today.
Great, thank you so much. I think I have, oh, I know I have a question from a little while ago that I think I'll bring up to anyone. Where would we measure, I'm not sure if they mean where or when, would you measure CO2 and what is the benefit of adding UV commercial air filters? And what about charcoal? So it was sort of three questions there. I'm not sure if that's more appropriate for Stephane or for Joey, but essentially CO2, UVC and commercial air filters, and charcoal.
I think we can both answer something. Anyway, I can just give a first insight, and Joey, you can complement or start if you prefer. CO2 is an indication, is a proxy that allows you to understand if ventilation is appropriate in your space, in the space you're thinking of. So the idea is to measure the CO2 where you have the people, essentially. So you don't put your CO2 monitoring where you'll not have anybody, because that's definitely, and there are a lot of monitoring equipment. In fact, it's used in the ventilation sector for decades. It was essentially used to reduce ventilation. By the way, it was used to reduce ventilation because of cost of energy. This approach right now that's put forward is because CO2 also tells you that you have a lack of ventilation. If CO2 increase without control in the space, then you know there is not sufficient replacement of air. So then you can think of solutions, and the recommendations are going in that direction. The very place you want to put it depends on the shape and the size of the room, but think of, in general things, you need to have it at the, especially around the breathing zone of the people, not too low, not too high, and especially in the area where you have people. So if you have a big auditorium, you will not put your CO2 monitoring at the height, the maximum height. Indeed, you will put that where you have the concentration of persons. Some are using also the return air and the ducting as being kind of a mixing thing to measure it. That was essentially the way it was used for cost reduction, energy cost reduction. Can be used also for other ways, other means, but that's, anyway, there is no one place fits all, but the principle are there. Put your equipment where you'll have to check if the persons are in a situation with or without a lack of ventilation or air replacement. Don't know if you want to add to that, Joey, just
So yeah, I'll add a couple items. One, I saw, I forget what school board it was, but they did measure CO2 measurements over the weekend, and they said, oh, the CO2 levels are good in this school.
good point.
I mean, it's comedically ridiculous.
Mm-hmm.
CO2 comes from people. So what you can do with CO2 is you can measure how much, or you could predict, we have evidence, we have tests, how much CO2 people produce, and then you know how quickly it's being removed. You could find out what the CO2 levels should be. I'm just looking to see if there's a link to our calculator. It's not on the OSPE website yet. We'll have it put in. I believe it's linked inside our documents. But if I can just share. Can you see the screen?
Not yet.
Unfortunately, it says you're starting to share content, but there's no content there.
Okay, maybe I stopped it. Maybe I'll just put the link in the chat. That's a calculator we developed, and based on what type of people are there, the type of setting tells you the ventilation requirements and the activities they're doing. You could find out what the CO2 level should be if the space is complying with current requirements. So you can say, oh, if it's off by plus or minus 50 parts per million, that's acceptable and fine. But if the space is supposed to have 1,000 parts per million and you're at 1,300, you know you're not getting proper ventilation. So that's a tool that we have. That's the first with CO2. There was other questions about UVC and I guess activated charcoal. For UVC, I wasn't so clear if they were discussing it inside like a portable cleaner. Sometimes you have like the 3-in-1 or 4-in-1 where you have UVC combined with HEPA. And sometimes you actually put UV lights near the filters in an air handling unit. When you combine it with a HEPA filter, and generally it's not that effective because the HEPA filter already filters out 99.95%. And in portable units, some of them might be designed properly, but I have seen ones where just the air goes through it too quickly and it's not exposed to the UV light enough to properly disinfect it. When it comes to portable units, you can use ones with UV if it's designed properly. My personal choice is I just avoid it. HEPA filters also filter out particulate matter from the air, which is also bad for you. So overall, they're more reliable, they're cheaper, and they have additional benefits. So for portable air cleaners, I go with HEPA filters. I don't go with ones that have UV, although UV can be used if it's designed properly. You sometimes have UV in air handling units. It could be used in different ways. Sometimes it's near the filters. It's supposed to actually clean the coils to ensure there's no bacterial growth or fungal growth on the coils. And usually that's not that effective for mitigating transmission of airborne diseases. It doesn't disinfect the air, but it has other benefits. So that's separate. And as far as activated charcoal filters, or activated carbon filters, I believe they can be used against volatile organic compounds. The way we deal with it in general is ventilation. You flush it out of the space and bring in outdoor air. Those can be used in certain circumstances. In commercial buildings, it's super rare. Sometimes they're added on to have like portable units as like a nice additional feature. It doesn't hurt, but it's not something I would focus on.
Okay, thank you. We also
If
have
I
a
may, on the
question.
charcoal, there is no study that have proven, especially in the SARS-CoV-2, for the SARS-CoV-2 virus and others like this, that has proven their efficiency. For other things, bioeffluents, that may be applicable, but if it's definitely for the virus side, not yet. It's still to be proven and studied, definitely. So I fully agree with what Joey just said.
Thank you. We've had two people ask if you can recommend a good portable HEPA filtration device or what to look for when choosing a portable device. Anyone have any thoughts on what to look for?
Well,
I
don't mind speaking just to give, because Stephane and Joey might want to break, but they can jump in as the engineers. But I get asked this a lot, and I think the guidance in the document is really good. And the general idea is avoid those what's called additive add-ons that are in many things like ionization, bipolar ionization, and these other fancy things. They're not proven. You have to look at the size of your room and look at something called the clean air delivery rate. And often these portable units are rated in terms of the size of the room they are designed to clean. But you can easily do that calculation yourself if you know the clean air delivery rate. It's usually more accurate than going by the size of the room in the promotional material. And I think the OHCOW calculator will help you with that. So the link is in the chat. And of course, cost and noise are major considerations. There's a great website called cleanaircrew.org that has a chart that helps you look at all these different factors. So I'm sure Joey and Stephane probably want to add to that too. I'll put Clean Air Crew in the chat.
Val beat you to it. It's already in the chat.
Oh, okay.
Joey, do you want to start?
So I think Marianne gave a good overview of like what you're looking for: a clean air delivery rate, noise, cost. Residential HEPA filters are generally much cheaper and better than commercial ones. I avoid commercial. It's been a big mistake. Residential ones are great. If you want like specific recommendations, I'll tell you people I've spoken to. Levoit has a bunch of good ones, whether it's depending on the size of the room, the 300, the 400, or the 600. Those are good ones. One of the cheapest ones for the power I found is, it's at Costco. It's the Winix. You have to be careful. It has this additive stuff, this plasma or wave or whatever it's called. You can disable it, and overall it's $200, and it has a pretty good clean air delivery rate for that cost. Marwa's Atari has a list of, she kind of plots out all of them based on cost and how noisy they are and the clean air delivery rate. So that's kind of what you're looking for. And yeah, I'll end it there.
All good. So this definitely Marwa is a good reference if you want to compare, especially the performance, meaning the capacity of the system, the cost, and other conditions. So noise is good. But the other thing you need to add to this, and I think it's a start, validate that it is a true HEPA filter, which is there, because there are in the field those who are calling them HEPA, but not really true HEPA. So just make sure that this is the case. And also you have two types of HEPA filters that you can find in the market. So those we call medical grade, H13, H14 if I want to take numbers, and H11, H12, HEPA 11 or HEPA 12 if you prefer, which are regular HEPA filters. So depending on what type of application, if it's for your home, if it's for a classroom, the regular HEPA is doing a great thing. If it's for a care center setting where you have a lot of potentially infected person, then you will go towards the medical grade. Or if you have a condition or you want to buy that for someone which has a special condition, then you would like to go to the medical grade. Indeed, the downside of the medical grade is the cost. So you have the regular one, which you can find for a couple of $100 for a regular room in a house or whatever, but then you can jump quickly in the $1,000 for the medical grade. So that's the downside of them, but it depends on the level of risk, and Marianne explained that really well. So you evaluate your risk or the risk of the person you want to take care of, and then you decide according to that what grade you will choose. On top of that, noise, price, and also the replacement filters. As an engineer, always look at the cost, because what you want with your system is to be operating on the long term. So you need to know what it will be cost to replace the filters. Sometimes it's I'm almost not joking, it's sometimes more expensive to buy the replacement filters than the unit at the beginning. It's like for printers, it's the same thing with the cartridge for printers. So now the cost of filters have went down a bit, but last year it wasn't the case. So look at what it will cost to maintain it if you're in a setting that will need this filter to be replaced a lot, especially if you're dealing with a lot of dust and other potential contaminant in the air you're talking about. If you have pets, if you have other things, so you need to have kind of protection on the filter, kind of first layer, you want to check that. So there are a lot of different things. The main were definitely identified by Marianne and Joey earlier, but it depends on what is the level of risk and what is the special conditions you're dealing with.
Thank you so much. I'm just noticing the time. Time flies when you're having fun, and this was a fabulous session. And the documents that have been are amazing documents. Thank you all three of you for being involved, and to your entire group for being involved. They're fabulous. Kevin Hedges has a question in the chat. We're not going to get to it because I am wrapping things up, but he asked if anyone has used air purifiers for TB. I'm going to just close it up. If anyone has anything to put in the chat, you're welcome to do so while I just talk about next week. Next week, we have another Occ-COVID Conversations. It's a double header or a double build session. We have indoor air, public health, and COVID-19 with Amy Katz and Amy Tian Yuan Lee, who are both affiliated. Oh, no, sorry. Amy Katz is with U of T, and Amy Lee is with U of Waterloo. We also have Dr. T. Ryan Gregory, who will be in the second half talking about the science of mutation, variant risk and impact. What's new with the evolution of the SARS-CoV-2 virus? So we will have Dr. Kevin Hedges and Val Wolf monitoring those sessions. I hope everyone enjoyed the session as much as I did. I thought this was amazing. We had lots of questions. If someone had a question they really wanted answered that I missed, please feel free to go over to Facebook Live and put your question there. I'll do my very best to find out an answer for you. I don't want anyone's questions to have been missed. So again, thank you all for being here. Thank you for your patience as we went a couple minutes over, and have a great weekend.
Thank you. Thanks to OHCOW for sponsoring this. This is great. I want to thank Joey too, because he started this whole thing. So it's great
Thanks,
job.
Joey.
It was probably harder than he expected it to be, but it really came through. And I noticed Sandro from OSPE was on the line too, and thank him as well.
Absolutely. And as Ziad is saying, there's definitely a deep mutual respect between all the professions that were involved. I know it was more than just engineers involved in this, and I think that the collaboration has been wonderful. It made the document absolutely amazing. I've already shared that document with friends who've asked me questions in the past about anything related to masking, to air ventilation. I just went ahead and forwarded that on to some people I know. It's been fabulous. So thank you all. Dorothy, I will get that information that you're asking for in the chat. So everybody have a great rest of your day.
Thank you.
Thank you.
Thanks. Bye-bye.
Thanks,